So there is a place for IRIS-6. This was one of those. Subluxated cataracts is definitely a very shallow AC, though BHATS is very thin. A very shallow AC, I think it's much easier to go in with IRIS-6. So despite my financial interest in BHATS, I do use IRIS-6 once in a while. Yeah.
That's being so honest. Thank you, Suven, for that.
Yeah, thank you. So thank you, Partho, for this kind invitation. So let's get on with the horror show. Like Partho said, if you had your lunch, good. If you haven't, hold it. Okay, so watch this carefully.
Dr. Minu?
Slide advance nahi ho raha hai bhai. हाँ, ठीक है. So watch very carefully, very carefully. Enough horror. I have your attention now. Anybody feeling sleepy?
Nobody.
Thank you. Take it. Worth my effort then. Okay, so what I wanted you to watch was not or listen to it. You should have seen my two instruments. The phaco probe and the chopper did not move despite the nucleus dropping. So what we learn is we are in a land of ascetics. Be calm and composed even when faced with horrors like this. Okay? So assessment planning, enough of theory over here, consumables, technology. I'll show you some of that technology. Technique is important. And what is required in hard cataracts is patience, patience, and more patience. A little big basics. So that's the horizontal chop where your chopper is at the equator. That's your vertical chop where the chopper is right close to your phaco probe and goes only partial depth and the chop propagates. And a little bit away from the phaco probe would become diagonal, but it's technically a vertical chop. Watch this. How does a vertical chop work? I mean, we shouldn't have horror only. We should have some learning also out of this. Can I have the volume, please? Yeah. If you have any doubts about vertical chop, this is your place to learn. I'm not going to scare you. Those are all vertical chops. The chopper only goes partial depth. Thank you. The chopper goes partial depth. The chop propagates till the floor. Okay, that's vertical chop. So let's watch vertical chop. This is actually a diagonal chop. The chopper is away from the phaco tip, and there the chopper is only going partial depth, and the chop propagates to the floor and the base plate. Okay, so you'll see a lot of this in all our surgeries, all the hard cataracts. That is horrific. Definitely every hard cataract takes away a few seconds of your life, like it or not. And so this is, I wanted to show you a vertical chop. You must remember that we do not want to go to the entire depth of the nucleus, and you do not need to. The chop propagates. Now let's look at a vertical chop. So this is a vertical chop, a real vertical chop. You'll feel that give over there. Tuck, that is the give. That's when you know that chop has propagated. So there is a lot of science and technology over here. So if you're going to do hard cataracts, we do need to adopt vertical chop into our practice. Otherwise, there will be a lot of phaco energy being used and a lot of collateral damage. This is a real hard one. I want to show what difference red glow makes. This is OmniGlow off, no financial interest, and the OmniGlow on at 100%. And despite that, I really don't have much of a glow. And this is a real hard one. But you look how technique and technology help us. We need to do very little hydrodissection, just enough to have the nucleus rotate. Actually, once you have a few passes of that trenching, the nucleus anyway gets a little loose and it can rotate. So you don't have to be very aggressive about that. And then we begin with our chopping. That's a real tough one, but you see that chop propagates till the floor. These are all diagonals because I really did not want to take chances over here. I can do a classic vertical chop, but then you have to be, the balance has to be very fine, and you might actually damage the zonules also sometimes. So we need to be careful of that aspect. If I could just go through a little faster over here. Yeah, so you can see from that nuclear fragments that it's pretty hard. I'm sure all of you are good surgeons and you do face cataracts like this. We'll come to the horror show. The next one is definitely a little bit of a horror show. So here this went off well, and the lens in the bag, pretty satisfying. When should the CTR be placed? Like I said, I do use iris hooks. This is actually before I invented the BHEX. So watch this. I've done my capsular, I've got 2 minutes here. So little bit of hydrodissection, and I try to rotate the nucleus. Now that's the entire bag and a very hard nucleus moving. Not a very happy scenario. Had to do this. This is a very old lady. So I also sometimes use a technique where I progressively go deeper. If I don't get my vertical chop correct, I can progressively go, just hold and keep grabbing the nucleus and going deeper and deeper with the chopper. Yes, barely managed to get the 2 heminuclei fragments. Now begins my trouble, as I can see that equator, you can see at the 6 o'clock that equator of the bag is coming. It's just popping up and showing its face. I don't like it one bit. There's a little bit of wisp of cortex over there, but most of it is the equator of the bag. It's not happy. Let's put a little bit of viscoelastic and inflate the bag. I was in 2 minds whether to put a CTR now, wait for the nucleus to drop. Options. So I used to be a VR surgeon in those days. I've hung up my boots now, like Partho. So you can see that equator of the bag. Now at this point I decided, no, I will not put a CTR. Let's try my luck, and that heminucleus can be used as a temporary equatorial support. Rotated that heminucleus so that I had supported the bag just to inflate the equator of the bag at that part. And let's try doing this phaco. If it sinks, we'll handle it, but if we get away, it's a gamble. And get away we did, but the bag kept coming. The bag kept coming. It was a very fine balance, and this is pre my BHEX, so that means we didn't have great machines also at that time. In fact, this went for the ESCRS challenging cases, I think, sometime in 2012 or something, or much earlier. I'm trying to repeatedly inflate the bag, and it is, I'm nearly done, yeah. So then we decided to put a CTR, and here we are threading the CTR. I kept that nucleus over there, and I said, okay, now let's get that CTR in place. We had got that heminucleus also divided into 2 quadrants, so I had enough, I could now safely put the CTR and preserve the bag. Thread the CTR. You've got to be very careful because these bags can be a little fragile also, and we've had situations where CTRs have gone through also. So let's just advance it a little. Put the CTR, and I'm sorry, yeah, and then we managed to phaco the nucleus, and to my satisfaction, we did have a good capsular axis, an intact bag, which allowed me to put in a 3-piece multi-piece lens, which is not available now. I don't know if some of the older guys will know. This was by Abbott, Clariflex, I think this was called. We don't have it now. So silicone lens. Yeah, so it was in the bag, and that's it. Thank you very much for your kind attention. I'll be happy to answer any questions later.
So thank you, Suven. I think you really made all of us sit up, and I'm sure nobody can sleep now. But any questions to Suven quickly? Yes, yes, sir. Can you introduce yourself? And yeah.
So I'm Dr. Vansh. My question is,
Sure.
as per conventional teaching, what I have learned is you put in a CTR as early as possible. Is that correct, sir?
As early as you need, and as
you
early as you
need.
can.
Yeah. Okay.
So the two are very subjective. So it's a hard cataract. You need to create space for the CTR. Okay, so how you do it, at what point you do it, after removing a cord and injecting doing a little hydro, because if the bag is full and you put in a CTR, there's a wonderful paper by Ike Ahmed and colleagues where the amount of zonular loss or damage because of insertion of the CTR is also there. It's a soft cataract. You have the cortical cushion. So your CTR, you can thread it through without any zonular damage. In a case like this, where I already know that my zonules are damaged and it's a hard cataract, I would like to play it, probably use temporary supports, capsular hooks or something like that. So it's a play. So it's a very diplomatic statement, you see.
Okay, yes. And the second question being, could you have avoided the difficulty by converting it into an SICS the moment you saw that the capsule, that there was zonular loss? If you converted it into a manual SICS,
Then I won't be able to present it here today.
I think jokes apart, SICS is a very good bailout, very, very good bailout. And this is something that we tell our residents, that please learn SICS well as ECC, IOL, because these are bailout situations where you can, without compromising the cornea or any other structure, in such difficult cases, you can put in a lens even in the bag and it can be done. So SICS, ECC, IOL are not redundant.